Hi, good morning to everyone. Welcome to today's webinar. We're continuing with our webinar series organized by Texas Children's Hospital, Fetal Intervention Division, and Baylor College of Medicine. Today, we're going to be covering our first webinar on the topic of fetal spina bifida. On today's webinar, we're going to be talking about different methods for in utero spina bifida repair. We're going to be covering different methods to do so, from the most invasive one until the least invasive one. We have speakers from all around the world sharing their experience and their overview about the technique that they're mostly implementing in their centers. And we will also be hearing a lecture towards the end of the webinar that will be covering the aspect of the timing to perform spina bifida repair. So before we start with the lectures, I would like to ask a question to the audience. Tiara, if you don't mind just showing the question in the poll, you will see the poll, and please feel free to answer the question that fits better with your practice. If you perform any in utero spina bifida repair, and if so, which one? Which one do you do for the most part? So we have a few seconds for all of you to answer, and then we will show the results of the poll. All right, so now we're going to show the results of the experience from this audience. So we have 63% of the audience that they don't do any in utero repair, and about 20% of the audience, they do open fetal repair. And we have 15% of the audience that does laparotomy assisted, and 4% of the audience that does mini hysterotomy. So thank you so much for completing that survey. Now we know a little bit better the experience that this audience has. And I'm gonna invite my co-host, Alarisa Sanchez, to introduce the first speaker. Shemi?
Hello, everybody. Thanks for joining us for our webinar, Texas Children's Hospital. The first speaker, I'm honored to introduce Dr. Tim Van Meegen. He's a maternal-fetal medicine specialist at Mount Sinai Hospital in Toronto, associate professor at the University of Toronto. Team research and clinical practice focus on prenatal diagnosis and treatment of fetal anomalies, especially CNS anomalies. He's authored more than 100 peer-reviewed paper, more than a 15-book chapter. He's a very active person, and he's the associate editor of Journal of Prenatal Diagnosis and editor board member of Ultrasound in Obstetric and Gynecology. By that way, he also sent me at least one manuscript for review for prenatal diagnosis per week. Thank you very much, Tim, for accepting our invitation, and all is yours.
Thank you very much, Shani, for that introduction, and sorry for sending you all these reviews. I think we very much appreciate the help that we can get from anybody reviewing these manuscripts, and thank you so much also for having me here. Presenting at your meeting. I will be presenting on open fetal surgery for spina bifida, and I don't think that this topic needs a lot of introduction for this audience, but I think it's really important before we start heading into therapy to understand why fetal spina bifida is such a great topic for fetal intervention. And as with many conditions that we treat in utero, spina bifida is really a two-hit condition, where you've got the primary spina bifida defect that causes the initial problem, but then the problems that we see after birth, such as the hydrocephalus requiring VP shunting and the lack of motor function, are really secondary things that develop later on in the pregnancy. And so if we can intervene early, once the defect has been identified, we can prevent these secondary problems from occurring. And so what are those secondary problems? Well, The first thing is the problems related to the defect in the lower spine and the exposure of the nerve elements there. And as you can see in open myelomeningocele, the nerve elements at the level of the lower spinal cord are exposed to the amniotic fluid and the outside world. And in the third trimester of the pregnancy, the amniotic fluid becomes toxic for the nerve elements and attacks the nerve elements and gradually damages the nerve elements. And so we can see that over the course of time, there is a decrease in motor function. The Baylor team has actually demonstrated that very nicely with these functional assessments throughout the pregnancy, where you see a gradual degradation of motor function and gradual development of clubbed feet over the course of the pregnancy. But so that's not a primary thing, it's a secondary thing that happens because of the gradual ongoing damage to the nerve elements. The second thing that will happen is that you get a progressive leak of amniotic fluid, cerebrospinal fluid from the lower end of the defect. And that will cause the hindbrain herniation that we see, so the KRI2 malformation, and secondary to that, development of hydrocephalus. And we can see over the course of the pregnancy, again, the buildup of fluid in the fetal ventricles and the gradual development of hydrocephalus. So again, the hydrocephalus is not a primary thing, but develops later in the pregnancy, in the second and third trimester, due to the primary defect of the spina bifida. And so when we see these gradual things evolving, the logical response is, well, if we can close the spinal defect during the pregnancy and we can stop that ongoing damage of the nerve elements and we can stop that ongoing leak of cerebrospinal fluid, well, then maybe we can stop these secondary effects from happening and we can improve the outcomes for these kids. And that's really what has been tested in the MOMS trial. And so this trial, driven by three major institutions in the US, so CHOP, UCSF, and Vanderbilt, really proved in a randomized fashion that in utero intervention for spina bifida improves the outcomes for the fetuses. And what you can see here is a brief summary of the results that were published in the New England Journal of Medicine in 2011, where you can see in the left column here the outcomes of the fetuses that went in utero repair, and in the right column here the outcomes of the fetuses that underwent postnatal repair. And so you can see that there was a significant decrease from about 30% for the risk of needing a shunt or dying postnatally, with a halving of the risk of actually needing a shunt. And you can see that in the postnatal group also, the motor function was typically worse than predicted, whereas in the fetal surgery group, the motor function was better than predicted. And overall, there was more than one level improvement in outcome, which was clinically significant. And this resulted in a much higher chance of fetuses that underwent in utero repair to walk independently at the age of roughly 30 months. Now, all of this came at a cost, and the cost was dual, so both to the fetus and the mother. The cost to the fetus was mainly an increased risk of preterm delivery and PPROM, and you can see that the average gestational age at delivery in the fetal group was about 3 weeks earlier than in the group that got treated after birth. And you could see that the risk of PPROM in the MOMS trial was about 50%, so not to be underestimated. On the other hand, we saw that also to the mom there was a significant risk, and so the MOMS trial showed a risk of pulmonary edema after the surgery of about 6%, and there was then the risk of oligohydramnios. Now, after the MOMS trial came out and showed these improved results for the fetus, this was quickly accepted all over the world, and many other centers took up on this procedure that had initially been reserved to the 3 centers in the US. And this is a slide already from a couple of years back, but you can see that at that time there were 34 active fetal surgery centers worldwide, basically spread all over the world, but with a predominance in North and South America and in Europe. Now, over time, even though this was the procedure as described in the MOMS trial, over time, people have started varying the technique a little bit. There have been changes in inclusion criteria, who gets the surgery and who doesn't. The maximum BMI at inclusion has increased in some centers. Some centers will accept fetuses with minor comorbidities, such as VSDs. The gestational age at surgery has been varying between centers. Some centers have tried to make a smaller incision. Some centers don't use the stapler device that I showed in the video. Tocolytics vary between centers, and then the neurosurgical closure technique and the uterine closure technique vary between centers. Now, despite all that variation between different centers worldwide, the outcomes for the fetus have really been preserved, at least for what is with regards to CSF diversion needs after birth. And we see that in these results from the National Spina Bifida Registry, which show data for roughly about 1,000 patients, 800 of which had, or 700 of which had postnatal surgery, and about 200-300 of which had fetal surgery, that there is still that preserved decrease in CSF diversion, with only about a 50% need of shunting or derivation in those that had in utero surgery, and about an 80% risk in those that had postnatal surgery. So despite our variations in protocols, the outcomes are roughly the same. But the complication rates are certainly different between centers. And so you can, for example, see that in our center here in Canada and in Poland, we describe PPROM rates of only about 15%, but at other centers will have PPROM rates as high as 70% in trans. Some centers describe a gestational age at birth closer to 33 weeks, whereas others show gestational age at birth of 36 weeks plus. Some centers have a very low shunting rate, as low as 18 to 25%, whereas others describe rates that are similar to the MOMS trial of about 30-40%. So really the outcomes vary quite a bit between centers in terms of complication rates. What do we know about the long-term outcomes for the bladder? Well, a systematic review of different trials really showed that for bladder and bowel function, fetal surgery probably does not improve the outcomes so much. And if you really put all of this together, we see that even despite fetal surgery, only a minority of cases will have normal bladder function, about 10 to 20%, but the vast majority will still have either overactive bladders or low compliance bladders, which will result in urine leakage in many of them, and will require lifelong clean intermittent catheterization of the bladder. And many of them will also need bowel management regimes to manage bowel function long term. Now, overall, so we see that we have an intervention that is good for the fetus and improves the neonatal and long-term postnatal outcomes. But all of this comes at a cost. We already described the risk of prematurity, but there is also a risk of major and minor maternal morbidity. And this is a systematic review and meta-analysis that we did together with the groups in London and in Leuven in Belgium. And so we looked at all the trials describing open fetal surgery, predominantly done for spina bifida repair, and looked at the risk of maternal complications. And if you look at major maternal complication, you can see them listed here. So it's severe infection, pulmonary edema, heart block, or complications requiring surgical interventions such as hemorrhage or placental abruption. You can see that the risk of these complications can be as high as 5%. In most series. And then more minor complications total about 16%. And even though we call them minor, they're not necessarily minor to parents, because things like chorioamnionitis, infections requiring antibiotics, milder pulmonary edema, transfusion, those are not necessarily that mild. And so if you look overall, about 1 in 5 women will have significant complications after open fetal surgery. On top of that, we know that when these pregnancies then ultimately deliver by C-section to prevent the risk of uterine rupture in labor, and they end up with 2 scars. So the scar from the fetal surgery, the hysterotomy scar, plus the scar from the C-section. And that certainly has long-term implications for the women undergoing these surgery. And we know that in future pregnancies, their risk of uterine rupture can be as high as 10%. So this is not a minor surgery for moms, but I think that overall, to summarize what I've shown here in the past 10-15 minutes in the past slides, overall we can say that fetal surgery has become the state-of-the-art treatment for open spina bifida and is now available in many countries worldwide. It certainly goes with improved outcomes for kids mainly improvements in shunt rates and motor function, probably does not affect bladder and bowel function as much. Despite uptake all over the world and dissemination to smaller centers, we see that we have preserved outcomes for the babies and kids. But there is still some significant maternal morbidity and uterine scarring, and centers report differences in outcomes requiring protocol optimization, I think, by comparing what certain centers do well and what certain centers do not do well. Thank you for your attention, and I'll be happy to take any questions during the Q&A time.
Thank you so much, Tim. I think that your overview about open fetal surgery was excellent, and there's a lot to talk about for the dedicated Q&A time. We're gonna listen to the next talk, and then we'll take the questions for Dr. Van Meegen and Dr. Abdallah together. So continuing with the series of lectures that we have for today, now that we have heard the standard of care, the open fetal surgery, we're gonna move on into the next technique, that is the mini hysterotomy repair for spina bifida. So Dr. Abdallah is one of the fetal medicine specialists who works with Professor Fabio Peralta. They have developed the approach of the mini hysterotomy that we're going to be listening about. Dr. Abdallah is a professor of fetal medicine at Citrus in Sao Paulo Ultrasound Training Center. She practices in Brazil, and she serves on the medical staff in the maternal fetal medicine unit at the Heart Hospital. She's also a consultant in the fetal medicine unit at Pro Madre Paulista. So without any further ado, I'm gonna let Dr. Abdallah present her technique and her results. Thank you so much for being here, Juliana.
Hello, good morning. Thank you, Professor Madalena. And thank you so much for inviting me to participate in this webinar. For me, it's a big honor to be here, especially with these amazing colleagues. And as you have said, I'm speaking here in the name of Dr. Fabio Peralta Group. And today I'm going to be talking about the mini hysterotomy approach for spina bifida repair in utero. So I will start with a brief introduction and then discussing how we do it. Then on the second point, I will show you the overall results, then the relation between the gestational age and the shunt rates. And after that, we will talk about the gestational age and the relation with the ability to walk. And we'll finish the presentation with some conclusions and some insights. So let me start describing our history, the history of our group through the spina bifida repair here in Brazil. Our first case was performed on November 2014. 2 years later, we published our first case series about the mini hysterotomy approach. On October 2019, we did the first spina bifida repair through the open fetoscopy. It was our first case using this approach. And then into 2020, we published the relation between the gestational age and shunt rates. And on this year, 21, just 4 months ago, we did our first percutaneous fetoscopy, but I have to confess that we are just starting in this approach. And just a few weeks ago, we discussed the correlation between the gestational age and the ability to walk. There I'll show the results to you. Today, we have performed a total of 362 mini hysterotomy, 25 open fetoscopies, and 4 percutaneous fetoscopies. So how we do it? We have tested modifications to the classic hysterotomy procedure that Tim showed using the MOMS trial. With the main purpose, we try to decrease the uterine injury and decrease the maternal morbidity. The inclusion criteria were the same using the MOMS, except the gestational age that we perform the repair until 26 weeks and 60 days. We don't use MRIs, we don't perform MRIs, and we don't limit the BMI. We use nitroglycerin for prophylactic tocolysis, and we dissect and close the dura. We dissect and close the musculofacial layer, And we do a primary skin closure. We never use patch for the skin in the open surgery. Here's a video showing our technique. So we perform a 2.5 to 3.5 centimeters sterotomy using an electric blade. Of course, you can see that we just do the same. The uterus is partially sterilized from the abdominal cavity, and the fetus is gently moved by external manipulation guided by ultrasound, so the spina defect can be located against the uterine wall, free from the placenta. And then here you can see the membranes. We identify the membranes and suture to the inner layer of the myometrium. We still think that this is a really important step to suture the membranes, to hold them to the sterotomy walls. We don't use staples. We don't have staples here in Brazil. And then 2 neurosurgeons operated the fetus using a microscope. Here you can see we are dissecting the neuroplacoid, and then we will dissect and close the dura, and then we'll dissect and close musculofacial layer. So we never use the patch for the skin, as I have said before. We close the defect in separate layers, and then this is the final step. So we are going to the skin to close the skin. That's it. After that, the uterine suture is performed in 2 layers, and before the last stitch is timed, the physiological solution is returned to the miniot cavity until the amount of fluid was considered normal. And after the surgery, the patient stays in the intensive care unit for at least 12 to 24 hours, and she stays in the hospital under observation for at least 5 days. Let's talk about the overall results. So this is our results that I show to you now are based on our last statistic analysis done in June of this year. We had already performed 338 spina bifida repairs, and 264 cases are over 20 months old. 31 cases having completely follow-up. 70 cases are still in utero, and 25 infants are over 12 months old. So let's look at our results. We had 3 cases of incompletely closure. We had similar results comparing with the mom's trial. We have a high number of perinatal death, probably due to inadequate prenatal assistance. We don't know how exactly why these deaths occurred, as no necropsy was performed, was not allowed by the parents, and there were no signs of infections and no signs of placental abruptions. The gestational age at the liver was similar. The distribution of the livers according to gestational intervals was different. The rate of early preterm birth was lower in our group. We also had, that's not in this table, a longer operation time, but our surgery to deliver interval was the same as described in the post-mom's experience. So this could be explained by the size of the sterotomy, a smaller size itself, and by the way in which the membranes are attached to the myometrium in our cases. The frequency of maternal adverse outcomes was similar. We had a lower frequency of uterine dehiscency and abruption, probably due to the small size of the incision. About the neurologic outcomes, the need for repair of the dehiscence at birth was smaller. So the main difference in our technique is the size of the sterotomy, and probably this could help to prolong the latency to the liver, even after a longer operation time that we have. So let's talk a little bit more about the neonatal results. In 2020, we analyzed the need for ventriculoperitoneal shunting and rates of shunting before and after 2 complete weeks of age. This was a retrospective study between October 2014 and February 2019. And most of infants, ventriculoperitoneal shunting was performed by other team. And this is probably a week of our study. Brazil is a really large country, and we receive patients from different regions, and they come back to their cities to delivery and follow up with different physicians. So another neurosurgeons will take care of these kids after the delivery. In total, we have 164 cases. That's our final number. We noticed that there was a significant positive correlation between the size of the hysterotomy and the gestational length, and also a positive correlation at the time of fetus surgery, the time of the surgical, the length of the surgical time, and gestational age. The interval from fetal surgery to delivery have an inverse significant correlation with the gestational age, and there was no association between the rate of premature ruptures of membranes and gestational age at the time of the surgery. So when we repair early, we do it faster and through a smaller incision. The multivariate analysis of this study showed that both gestational age at the time of the repair and fetal lateral ventricle to hemisphere rate were independent predictors of postnatal shunting, and the probability of an infant to receive a shunt increased exponentially with gestational age and ventricular hemisphere rate at the time of fetal surgery. And then we built a formula, and we used this formula to calculate the probability to the needing for ventricular shunt and to counsel the family just before the surgery. And the final part of the presentation, we will discuss the impact of gestational age at fetal surgery on the infant's ability to walk in relation to pre-surgical predictors. We just published a paper in the prenatal diagnosis with these numbers. We included 114 cases in total, but our final number was 69 cases. We lost 36% of our initial cohort who were scheduled for the formal neurological follow-up, and they were not able to attend due to the restrictions imposed by the pandemic. We included the children who had formal neurological evaluations at 12 and 30 months. The median gestational age at delivery was at 35.3 weeks. In many studies, if it's not clear if the ability to walk independently comprise the use of any kind of orthosis or not, that's why we perform 2 separate analyses. So the first one consider a normal ambulation as the ability to walk without anything, without orthosis. And the second, considering a normal ambulation as the capacity of walk with or without orthosis. Let me show you the results of the first one analysis. So in this analysis, 30.2% of our patients were normal ambulators. And studying this baby with the ability to walk without anything, the significant predictors were the gestational age at the surgery, the upper anatomic level, the absence of clubfoot, and the normal limb movements before the surgery. In the multivariated analysis, the upper anatomic level remained as the single predictor of the probability of walk without orthosis. The gestational age was not a predictor here, probably we think because there was a small number of patients in this group. We had only 22 cases included here. And we think that we still need more cases to perform another analysis according to the gestational age at the time of the surgery and the ability to walk. without orthosis. In the second analysis, 64% of our children were able to walk, considering the ability to walk with or without orthosis. And the main outcomes variable was just the same as I described before. The gestational age, the upper anatomical level, the absence of clubfoot, and the normal limb movements before the surgery. And in the multivariate analysis, the gestational age at surgery and the upper anatomical level remained as significant predictors here of walking with or without orthosis. We also built a formula here calculating the probability to walk according to the upper anatomical level of the lesion and the time at surgery. So the conclusions, the fetal myelomeningocele repair is feasible through a mini hysterotomy. It allows a safe and an early correction of the fetal spina bifida. And the mini hysterotomy, the children who undergo this correction at an earlier gestational age are less prone to needing ventriculoperitoneal shunts and have increased probability of walking with or without orthosis. And for our group, it makes sense based on the two-hit hypothesis that we should protect the medulla from the amniotic fluid as early as possible. So we think that the early is the better. And it's really important to have the correct information to counsel the parents. And this should be objective and neutral. And we suggest the individualization of the technical approach. We use that formulas that I showed to you that were described in our papers to counsel the families. And our finds might raise a discussion that we are having here in our group about which is the best technique. We are not sure that we have a gold standard now for the fetal repair of the spina bifida, because currently we have different variations of the open repair and different endoscopic approaches. We do think that there's not only one way to treat, but different ways to treat according to the gestational age, according to the specific variables of the fetus. This is our flow chart for the treatment for the spina bifida repair. In pregnancies below 24 weeks, we prefer to perform the open surgery, the mini hysterotomy, because we think it's too difficult to perform endoscopic access, considering the size of the instruments. It's really hard to our group. Between 24 and 25 weeks, we have multiple choices, depending on the type of the lesion, the size of the defect, the location of the placenta. And after 26 weeks, probably the percutaneous fetoscopy to be the best option, but we still have some problems to suture the membranes in the percutaneous fetoscopy. We're just starting this approach. We have a small and initial experience, and we're still in the learning curve. So this is our fetal surgery team. Thank you for all attention, and I'm available here for the Q&A questions. Thank you, Professor Medella.
You're on mute, Dr. Sands.
Sorry, Juliana, that was an excellent presentation. Thanks so much for sharing your data with us. I think that it showed the probably one of the largest series in mini hysterotomy spina bifida repair that there are out there in the world. So thanks so much for sharing that with us. We have a few minutes to approach some questions to cover both Dr. Van Meegen and Dr. Abdallah's presentations. I see here there's a question for Tim. It says, how do you sedate the baby during the course of the open fetal surgery?
Yes, I think that's a very important part of the procedure, and we didn't speak about that in my talk, or I didn't stress that enough. So first, the fetus is partially anesthetized transplacentally. So these moms undergoing open fetal spina bifida repair are under general anesthesia. and certainly part of the anesthesia passes transplacentally. Second, and you may have seen it in the video and I didn't talk about it, but once the fetal spine is exteriorized and once we have access to the fetal buttocks, we give a small intramuscular injection of anesthetics. So fentanyl basically in combination with rocuronium to paralyze the fetus during the surgery.
Magda, can I ask 2 questions from Juliana? Juliana, it was a great presentation. Thanks. My first question is, from the scheme that you show different options, what percentage of the patient you in Brazil get them before around 19 to 24 weeks come to your center?
We have a problem here that the patients, they arrive to us not so early in the pregnancy. So we still don't have a lot of patients at 19 and 20 age, gestational age, because they really arrive later. But we always try and we recommend the patients to do the mini hysterotomy until the 24 weeks. We cannot perform the endoscopy before 24 weeks. The uterus is really small. The instruments are really big to perform the surgery into early gestational age. That's why we are discussing if we need to decide not which is the best technique, but which is the best technique for the gestational age. We are not sure if we will have only one technique approach, if we will have a gold standard. But we think that at least at this moment, we don't know what will happen the next month and the next year, but at least at this moment, we think that we need to individualize according to the gestational age, and if it's too early, we go to the open surgery, and we use the mini hysterotomy as our open surgery. And if it's too late, we can try to do the endoscopy. But we are beginning the endoscopy, so we have you saw the data. We have a very different experience with the open surgery that we have been done in the last 5 years, and in the fetoscopy approach that we have been done for one year and a half.
Thank you.
But of course, that I want to hear the other colleagues about this question, because this I think is a very difficult point to with different views to discuss.
Juliana, they're asking in the questions if you are having an extensive lesion, are you still using the mini hysterotomy, or would you decide for another technique if you see that the lesion is really large?
Okay, thank you for the question. No, we have never performed the classical hysterotomy. Even with the larger lesions, we can do it using the mini hysterotomy. So we don't have any cases that we need to do a larger incisions. We can do it using the mini hysterotomy.
There's an interesting question for Tim. I think Saul asked you an interesting question. Do you think spinal closure technique, myofascial flap, can affect bladder and bowel function?
That's a very good question. I think nobody has the answer to that. The neurosurgeons are much less evidence-based than I think the obstetricians and the MFMs in the audience. And if you really look at the research that has been done over the past 50 years into how you should close a fetal spina bifida, or how you should close a spina bifida after birth, it's really very minimal. And different centers use different techniques, and there's really no objective data on the best surgical approach, even though that should have been available since long. Some centers will close a myofascial flap, some centers will not. Some centers will use a patch, some centers will not. Some centers will tuberalize the spinal cord, some centers will not. And really, we don't know if it matters. I think the only evidence for the myofascial flap at this point is that it probably creates a better leak-proof seal than not closing the myofascial flap. So most centers will now be doing that. There is maybe a little bit of evidence that it can decrease the risk of inclusion cysts, but again, very, very little evidence at this point. So whatever technique you use at this time is right, I think, as long as you close the skin.
Thanks for that. We have a question for Juliana from Dr. Raul Usin. And I think that this answer is going to be connected with what Dr. Echegaray will be presenting at the end of the webinar. So the question is, what is the maximum gestational age to operate in your center, and why not operate after 29 weeks?
Yeah. I don't think this is the only question for me, Madam. We don't operate after 29 weeks because we have a baby that it can born, it's the viable pregnancy, so it's too late to perform a intrauterine surgery, and we have to think that we have the mother, so it makes sense to operate a baby when we do it early. And the spina bifida repair is a neurologic condition, so we think that we need to correct it early in the pregnancy to protect the central nervous system. So probably it makes no sense to do it too late because the baby is almost born, close to the delivery. And until few months ago, we only performed the surgery until almost 27 weeks. But we have a few cases now, and we are just studying until which week we will perform endoscopy, if we go until 28 or not. But today, our protocol is to go until 27 weeks, that the gestational age that we do the repair.
Thank you for that. And also, Juliana, you showed that in your logistic regression analysis, earlier gestation rates at surgery was a predictor for those babies being more able to walk independently, right? So that would explain also the answer to that question.
Yeah, and it's important because it makes sense. The number is just showing what they think about the two-hit hypothesis for the spina bifida. So we think that makes sense, that we need to correct early, and the number is just showing what we have known for a long time about the pathology of the disease, the etiology of the disease.
I'm going to take one last question for you, Juliana. Sorry.
Magda, if you don't mind, I think, we need to move on, and then we can maybe at the end come back for QA to respect of everybody's time. Sure. Again, it's my pleasure to introduce the next speaker. The next speaker will be Dr. Michael Belfort. He's my boss. We're working together for a decade. He's the chair of the Department of Obstetrics and Gynecology in Baylor College of Medicine. Also, he's a in-chief OB physician at the Texas Children's Hospital. Dr. Belfort published more than 400 peer-reviewed publications. He had a very wide range of research interests that's coming down from fetal surgery to the critical care obstetric, prevention and treatment of obstetric hemorrhage, multidisciplinary management of placenta acquisition spectrum, maternal brain blood flow, and recently he's getting involved in uterine transplant. With that said, unfortunately, he's traveling now from Belgium to State. He couldn't present here. He's probably should be in a plane at this point, but we have his record lecture. Thank you.
Hi. This is Dr. Michael Belfort. I'm going to talk today, in the short time that I have, about fetoscopic meningomyelocele repair and talk a little bit about our new technique that we have developed. Anytime you talk about fetal surgery, I think it's always good to acknowledge Dr. Michael Harrison, who really started fetal surgery in San Francisco in the 1980s at UCSF Children's Hospital. Open fetal surgery, which is the opening of the uterus to expose part of the fetus for surgery, was really pioneered in the 1890s 1980s and 1990s by Dr. Harrison, and received a big boost in 2011 when the MOMS trial was published. And this was a trial that showed that fetal spina bifida repair is beneficial to the baby. As a result, many women now are having open fetal surgery worldwide. There are, however, significant risks, both short and long term, of open hysterotomy fetal surgery. And this is the reason why we developed a fetoscopic program. And I would like to talk today to you about that program. Spina bifida is a quite common condition, about 3.4 per 10,000 births in the United States, which equates to about 1,400 to 1,500 babies born with this condition per year. 90% of these are sporadic events with no genetic component. There is a two-hit hypothesis which explains why fetal surgery makes sense. The first hit is the actual congenital anomaly itself that causes a certain amount of damage and loss of function. But the second hit is ongoing damage that is caused by exposure of the spine to the amniotic fluid, to trauma from bumping up against the inside of the uterus, and potentially from stretching as the sac enlarges. So there is a first hit that we cannot avoid, but the second hit, by using fetal surgery, is something that could be perhaps alleviate or minimize the second hit. Now, why is fetal surgery in the case of spina bifida regarded as useful? There are two reasons. One is to reduce the incidence of hydrocephalus and the need for a shunt after birth. And two is to preserve mobility, to preserve ambulation, and to preserve lower limb function. As you know, when you have a leakage of spinal fluid from the lower spine, the cerebellum will descend into the base of the brain and the foramen magnum and the posterior fossa, and cause some obstruction to the fourth ventricle and the drainage system. And this ends up resulting in large ventricles that cause ventriculomegaly. And if the cerebellum remains there for the entire pregnancy, can cause a high rate, a high risk for the need for a shunt due to hydrocephalus in a range of 90 to 95% of these kids if they're treated postnatally. This is what has to be done. A shunt has to be placed in the ventricle and then tunneled under the skin into the abdomen. And the problem with this is that there's a risk of infection. There's always a risk of failure or migration. And quite frankly, many of these children have shortened lifespan because of the shunt. When you talk about open hysterotomy, human meningomyelocele repair, one has to acknowledge Joe Bruno on the left and Noel Tulipan on the right, who did the first case. This was then taken up by the NIH, and in this video you can see what a open fetal surgery looks like. You can see that the abdomen is open, the uterus is then opened using a stapling device, and you can see the size of that hole in the uterus is often between 7 and 10 centimeters in the fundus of the uterus. So this is equivalent to a classical cesarean section and requires that this baby be delivered by cesarean section and any future baby be delivered by cesarean section as well. Almost always these children are delivered at around 34 to 35 weeks because of the risk of the mother going into labor. And in fact, in subsequent pregnancies, there has been shown to be a 10% rupture of the uterus rate. So here you can see the baby being given some anesthetic. This is a paralytic agent, becuronium in our hospital, as well as some opioid, fentanyl, and some atropine. And then the neurosurgeon will do a standard neurosurgical procedure on the baby's spina bifida. So the neurosurgeon is at this point dissecting the sac, releasing the placode, and then closing the lesion. At the end of the surgery, the baby's skin is closed, the uterus is then closed. We fill the uterus again with warmed Ringer's lactate, and we carry on with the pregnancy as much as possible. This was tested in the New England Journal article of March 17, 2011, the randomized trial, and this was called the MOMS trial. And what it showed is a significant increase in mobility in the prenatal surgery group, 42% with the surgery versus 21% without the surgery, and a decreased risk of hydrocephalus by 30 to 50% reduction. So clearly, the meningomyelocele repair in utero has benefits both in terms of hydrocephalus and in terms of improved mobility. This is the latest paper on a 5 to 10 year follow-up on these children. This was published yesterday, in fact, online by JAMA, and they followed up 154 children that were enrolled in that trial, 78 with postnatal repair, 76 with fetal repair, and they showed that the fetal surgery kids walk faster, they have a better gait, they have better mobility, and they're less likely to have worse function than the anatomic lesion level. So ongoing reports of good outcomes with fetal surgery. So we know that this is good for the baby, but what about the mother? We know that the mother has an increased risk of a ruptured uterus. She has to have a preterm cesarean section. She will need a cesarean section for all future pregnancies, and there may be an increased risk of placenta prurita because of repeat cesarean sections in the future. When we do the cesarean section, we'll often find omentum attached to the scar. Sometimes we'll find bowel attached to the scar. And underneath that, often we will find an area of dehiscence of the uterus. And this was reported as high as 13%. So 35% of women who underwent prenatal surgery had a thinned area of the uterus, and about 10% of those people, as I've said, will rupture their uterus in their next pregnancy. And then I've mentioned the risk of potential prurita. So what are the options? Well, the options are not to offer the surgery, to improve the open technique by maybe doing it through a smaller incision, or to develop a new way of doing it, and that's what we decided to do. And we decided to go with fetoscopy. Again, these two men were the first to do fetoscopy, but they used very large instruments, and their results were actually terrible. This baby died, this baby died, this baby had a bad outcome, needed a shunt, and still had a significant deficit. So did this baby, postnatal revision and shunt. Diana Farmer did 3 cases in San Francisco fetoscopically. This baby died. This baby had a postnatal revision and a shunt. This baby required revision and shunt and then died. And so at the end of that, she wrote that she thought it was unethical to pursue minimally invasive fetoscopic meningomyelocele repaired humans until this had been validated experimentally and studied in carefully designed clinical trials. I'm not going to talk very much about the totally percutaneous method that was developed by Thomas Cole, but be aware there is a totally percutaneous method that is done both in Germany and in Brazil, and more recently now in the United States. But the reason that we continue to do our method the way we do is because of the preterm delivery rate with this methodology. These babies still deliver around 34 to 35 weeks on average. So we went to Barcelona and we collaborated with Jose Luis Peiro and Elena Carreras, and we didn't collaborate with Messi, but we did go watch him play soccer. While in Barcelona, we developed a technique to create and to practice our surgery, but the team in Barcelona were using a different technique. They were doing a patch and glue technique, and we decided that we would move forward with a different technique. So we came back to Houston, and using a doll, a ball, and some chicken, we developed a model that allowed us to practice and develop a two-port technique to do this repair. We have now become a lot more sophisticated and developed this model that is a much more realistic simulator, and we have made a silicone baby that allows us to create a simulated lesion, and then we're able to do the surgery to a much more realistic effect, including putting in the ports, using the diathermy, etc., etc. So this is the way that we practice. We train people, and we continue to develop our skills. We then went back to Barcelona, and we did the surgery in some sheep, and then we came back to Houston, and we did our first human patient. Initially, our technique was simply to free the placode and then to close the skin and dura over the placode and to cut relaxing incisions if needed. And here you can see that technique. We would cut around the placode, and then we would suture in a single layer repair. So we did the first surgery at Texas Children's Hospital, and ultimately we published our results on this surgery showing the outcomes. Once we had standardized our technique after the first 12, we got very good results, but we still had some leakage of fluid in around 10% of patients with CSF, and we still had about 30% of our patients meeting the MOMS criteria and being treated for hydrocephalus. So we thought there's a better way of doing this, and we further developed our technique into that similar to what was being done at Children's Hospital of Philadelphia at the time, which was a multi-layer closure. Our multi-layer closure involves placing a Durapair patch over the placode once it's been freed, then creating muscle flaps, as you can see here, and then closing the muscle flaps over the patch and closing the skin over the muscle flaps. And here you can see the technique. The uterus is exteriorized. You then use ultrasound to place a port. This is a 12 French port. You then place a second port, and the surgery is done using a very small scope and a two-port technique. Here you can see the placode, and this is a myeloschisis. You can see the baby getting its anesthetic. You can also see that we remove all the fluid, or a lot of the fluid, amniotic fluid, and we fill the uterus with CO2 gas. Here you can see that the placode is now freed up. In this case, we are cutting relaxing incisions. This is a rare situation. When there's not enough skin to close over the lesion, we tend to make relaxing incisions, although at this point in time now we've got a lot better and do not really need relaxing incisions anymore. There you can see the patch being placed over the placode, and now we're going to cut the myofascial flaps. We use diathermy to do that. We cut the paraspinal muscles, and then we do this on either side. developing these flaps, which are then sutured in the midline. Here you can see the flap being sutured over the patch that is underneath. This is the second layer. These suture are sliding knots, and here you can see the skin being closed. In this case, we were closing just the skin over the patch and not with the myofascial flap. In the background, you can see the placenta. And here you can see the skin being closed with the relaxing incision opening up on the side. And here you can see the closed lesion. This is what it looks like at the end of the surgery. Instead of a 7 to 10 centimeter lesion, we have two small oversewn openings. And this is what it looks like at the time of cesarean section. This baby was delivered because it was breech. When we looked at the outcomes of our initial series with single layer closure and our 3-layer closure series, we showed significant improvements. Very low rate of preterm rupture of the membranes, less than 30 weeks. It was in fact 0%. Delivery at a mean of 37.6 weeks and a median of 39 weeks. We had 71% of our patients delivered at greater than 37 weeks, and 47% of our patients had a vaginal delivery. In addition, reversal of hindbrain herniation is now 93% compared to 60%. We had zero leakage of CSF at birth, and the babies that met criteria for a shunt were 58%, and treated for hydrocephalus 33%, which is actually less than the MOMS trial. This is what the scar looks like at birth. This is what a few of the babies look like. You can see that the relaxing incisions heal to some extent, some completely, some are still slightly open when the baby's born, but they close very rapidly. So in conclusion, our 2-port fetoscopic meningomyelin seal repair offers very significant maternal benefits with excellent fetal and neonatal non-neurologic outcomes. Brain imaging studies and early neonatal neurobehavioral tests are very encouraging, suggesting no major differences in CNS structure and function between the 2-port fetoscopic and our open repair babies. We very recently presented data at SMFM that clearly shows that when you compare fetoscopic technique to open technique, the babies have a lower rate of respiratory distress syndrome, and a composite neonatal adverse outcome is a much lower incidence in the fetoscopic repair. Obviously, we need larger numbers, and longer-term follow-up is going to be necessary. So we feel that the fetoscopic versus open is better for the mother, better or equal for the baby, with equal central nervous system outcomes. There's no increase in maternal or fetal complications. The mothers can have a vaginal delivery at term. You can induce labor, and there's ideal obstetric and neonatal outcome. Thank you very much for your attention. Hi, this is Dr.
Okay, thank you very much, everybody. I think I messed it up. It was first going Dr. Ramin Ishmael and then Dr. Belfort. But with that said, now we are going to Dr. Ramin Ishmael. He's a great friend and a very also great colleague and collaborator. Dr. Ramin Ishmael has served as the director of Los Angeles fetal surgery at University of South California since 2006. He's also a professor of obstetrics and gynecology and pediatric and surgery as a courtesy. His main clinical focus is treatment of the fetus via minimally invasive fetal surgery. He's working in this field for close to 2 decades. He published more than 150 peer-reviewed manuscript and textbook. And with that said, Dr. Ramenshmine is all yours.
Thank you, Shami and Magda, for inviting me to speak. I look forward to describing the percutaneous physioscopic repair of open spina bifida. As you've already heard, in 2011, a very important study, the MOMS trial, was published. And this trial showed that prenatal surgery improved outcomes in the fetus. This surgery, as you know, was done using the open technique, so maternal laparotomy and hysterotomy. And the advantage of this approach is obviously surgical access. Here you can see a fetus with a myeloschisis, and surgical access is ideal as the baby is basically presented to the surgeons. This has already been reviewed. The MOMS trial showed improved outcomes as far as the neurological prognosis for the baby. But of course, there are risks, both to the pregnancy, but also the maternal risks. As has been alluded to earlier, this study showed that there was a 10% risk of uterine rupture for the next pregnancy. So there's a uterine legacy associated with open fetal surgery. But I think something that has not been emphasized is the timing of the uterine rupture. In the study, the mean gestational age of uterine rupture was 28 weeks gestation, and it ranged between 26 and 32 weeks gestation. So calling this similar to a classical uterine incision, I think, is not necessarily correct. Classical uterine incisions are usually associated with rupture at the time of labor. These pregnancies were associated with rupture prior to the onset of labor, very difficult to predict. So the uterine legacy of open fetal surgery is one not only that affects the index pregnancy, but also future pregnancies. So the question, of course, came up, how can we provide the benefits of the prenatal repair, but minimize the risk to the pregnancy and to the mom? And that's where the physioscopic approaches began. And Dr. Belfort reviewed the history, which included the percutaneous and the laparotomy assisted. In regards to the percutaneous approach, one person who really pushed the field forward was Dr. Lapa in Brazil. And she did a lot of basic science research in small animals as well as in sheep. Here, this is a sheep uterus, where Dr. Squintero and I would come down and visit as she was doing the fetal sheep repair. And one of the first things that had to be shown was that it was technically feasible, and she showed that. And also, there was also concern regarding the carbon dioxide insufflation of the uterus and whether that is associated with the poor outcomes. And basic science studies, as well as in our experience, in which we did fetal blood sampling at the conclusion of 7 of our prenatal repairs, basically showed that there was no fetal acidosis. And I think that issue has been put to rest. The advantage of the carbon dioxide insufflation, of course, is visualization. And so we can visualize and are able to do the surgery, which would not be possible in the amniotic fluid medium. Of course, the amniotic fluid would become very discolored at the time of surgery if we were trying to do that repair. So when we talk about fetal repair, it's very important, I think, for the audience to know that this is actually very complicated because there's the maternal approach, and we've been spending some time talking about open versus the physioscopic. There's a neurosurgical aspect. How many layers are closed? Is it a 3-layer closure, like with a myofascial flap, or 2-layer closure, which Dr. Belfort showed in one clip where he was closing the skin over the repair patch? Is there a patch being used? Yes or no? If there is a patch, what type of patch? So when we look at outcomes, it's very hard to compare because there's various differences and the variables need to be able to match up to really compare apples to apples. I will spend the rest of the talk talking about the percutaneous repair. And usually we use only 3 ports. In this picture, this example, there was a 4th port placed. But as you can see, the point of the percutaneous repair is that the uterus remains in situ. There's no exteriorization of the uterus. This is a laparotomy assisted technique that was done at our center due to the graciousness of Dr. Belfort's group, specifically Dr. Shami, who came and assisted us in this surgical approach. But here you can see that a maternal laparotomy is performed to allow for exteriorization of the uterus. We do perform a 3-layer closure at our center. So I'll be specifically showing you our percutaneous approach. And here you'll see that we have 3 ports. One is the camera showing the lesion, and the other 2 are instrument ports. This is a myeloschisis, and this baby happened to have bilateral club feet. And you can see that this is the neurosurgeon here releasing the neuroplacode, as was done in the previous videos. And here you can see we are releasing the skin, undermining the skin to allow for laxity of the skin for hopefully a primary skin closure. The myofascial flap is created. And then we place a DuraPair patch over the released neuroplacode that's now in the spinal canal, and we close the myofascial flap, thus creating 3 layers. So above the neuroplacode, you have the DuraPair, you have the closed myofascial flap, and then we try to close the skin. And sometimes the skin cannot be closed primarily. And in our center, if the skin cannot be closed primarily, we most of the time so far have placed a secondary bilaminar patch, basically artificial skin, if you will, and we suture that over, thereby protecting our myofascial flap layer. And that is the finished product right there. So here in this slide, you can see a primary skin closure, which we're able to do most of the time. But if we cannot close the skin primarily, we'll have to place a skin substitute. These are some of our kids who've undergone either technique, and you almost really can't tell in the finished product whether we closed the skin primarily or used a skin substitute. We have used relaxing incisions. This, by creating a relaxing incision, allows for enough skin laxity to close the suture line primarily here, the skin primarily. So basically, what are the advantages of the percutaneous technique? It is the most minimally invasive for the mother. So basically, you can see the maternal abdomen 2 weeks afterwards, there's 3 tiny incisions. There is no large laparotomy incision. So just to briefly review outcomes of the fioscopic approach, I have to mention Dr. Sanz Cortez's heroic work in taking all of these people together, like herding cats, and basically describing 300 cases of prenatal fioscopic repair at 12 months. And what we did was we compared the mom's trial results with all the fioscopic techniques combined. So basically, it's combining all approaches. So we had 300 patients in our registry compared to 78 patients in the moms and 100 patients post-moms. And we looked at maternal and fetal outcomes. Overall, the gestational age of delivery was not different, 34 weeks. Again, comparing the entire fioscopic cohort to the other, to the open technique. Now the fioscopic approach had a higher rate of vaginal delivery. There was no uterine dehiscence, of course, because there was no large uterine scar. Spinal repair site dehiscence was 20%, but this involved a lot of early cases. I think now it's very negligible. The 1-year shunt rate was equivalent. Improvement in motor function was about the same. Basically, perinatal outcomes were about the same. Now, specifically looking at the percutaneous physioscopic repair group, Dr. Lapa and our group looked at all of our cases combined, and we described our outcomes using the percutaneous physioscopic repair approach and described the CSF diversion rate as well as ambulation and urological findings. The inclusion criteria is similar to the moms, except for the fact that patients are operated on up to 27 weeks and 6 days. This is the list of people, centers involved in this paper. Most of the patients came from Dr. Lapa in Sao Paulo. So there was 170 consecutive patients. At 12 months, 103 were looked at. And as far as the CSF diversion rate, it was about equivalent between the percutaneous approach and the open technique. As far as independent ambulation, very similar, and bladder catheterization at 30 months, again, very similar. So in conclusion, the infant and childhood outcomes after the percutaneous physioscopic approach was similar to the moms. Obviously, the advantage of this technique is it's minimally invasive for the mother, so basically providing the same benefit to the baby with minimal risks to the mother. So I have 2 more slides. I would argue the most important ones. What are the advantages and disadvantages of the percutaneous technique to the mother? Well, obviously, no laparotomy. So as far as recovery is concerned, the recovery for the mother is like you'd think of any other surgical technique, whether you're doing a cholecystectomy laparoscopically versus laparotomy. There's no hysterotomy. So we already talked about the benefits of that. This patient is allowed to have a vaginal delivery at term for the index pregnancy and all future pregnancies. As far as anesthesia is concerned, the uterus remains in situ. So unlike all the other techniques in which the uterus has to be exteriorized, to do that, you need to have uterine relaxation. And to maintain this uterine relaxation, you require deep general anesthesia. That is not the case for the percutaneous technique. We can do this surgery primarily with intravenous anesthesia with minimal inhalation agents. So we're typically at around 0.3 to 0.6 MAC. So less inhaled anesthesia, less hemodynamic derangements, quicker, improved recovery. Our patients do not need to go to the ICU after delivery. The average hospitalization after surgery is about 2 to 3 days. So as far as the maternal considerations, really, this is, I believe, the best treatment option. Now, in regards to the pregnancy and the fetal considerations, the advantage of the percutaneous, I think the neurosurgical closure is roughly equivalent to all the other approaches. We have good surgical access, good visualization. So I think the benefit to the baby is equivalent, if not better than the mom's trial. As far as cons, our biggest issue has to do with the risk of preterm delivery. Currently, the average gestational age at delivery using the percutaneous approach is around 34 weeks gestation. There are many reasons why. I think that for a lack of understanding a better reason, it may be due to the fact that this is the one technique in which we cannot surgically plicate the fetal membranes. So in order to place our surgical instruments percutaneously, we do it under ultrasound guidance. And upon removal of the trocar, we basically remove the instrument and hope the uterine incision closes, kind of like what we do for fetoscopy for twin-twin transfusion syndrome. So we have a relatively increased risk of leak, membrane separation, and that constellation of findings basically results in an average gestational age at delivery of 34 weeks gestation, which is acceptable if you're talking about the mom's results, open maternal field surgery, which is about equivalent. The other potential con of this approach, it has to do with surgical access, particularly if the placenta is anterior. If the placenta is anterior, we have to look for a placental free zone and able to place all three trocars. And so that can sometimes be a limiting factor if there is no window to place the trocars. That's one of the reasons why we like to wait till around 26 and a half or 27 weeks gestation to hope that a window does develop to have room to place our surgical instruments. So that's our percutaneous phaeoscopic approach. I, of course, want to acknowledge Dr. Lapa, who really was the spearhead for this approach.
Thank you so much, Ramin, for that excellent presentation on the totally percutaneous. We will have some time for discussion and for questions. But before, we're going to introduce our last speaker. Our last speaker is Dr. Adolfo Echegaray. He is a specialist in obstetrics and gynecologist and the director of the fetal medicine unit at the Hospital Universitario Austral in Buenos Aires, Argentina. He is also the co-director of the fetal medicine program there, and he is the director and professor for the diploma in fetal medicine at the Austral University. He is going to present his experience doing open fetal surgery and comparing the outcomes of performing this type of approach before 26 weeks and after 26 weeks. Adolfo, the floor is yours, and I'm going to encourage the audience to type in any questions that you might have so that we can have a final discussion after his talk. Thank you.
Thank you very much, Magda, and thank you to the organizing committee for the invitation. So you have heard the previous speakers, some amazing talks about the different techniques and approaches of fetal MMC repair. In this last talk, I would like to address another topic, which is timing for fetal surgery. So as you know, the MOMS trial, which was published 10 years ago, established both the benefits and the risk of fetal surgery for MMC. A decade after its publication, we have seen three main trends in fetal surgery. The first one is validation. Yes, so a number of centers, not only from America, but from all over the world, have published similar results. This, together with the publication of longer term results, has translated into changes in the gold standards recommended by many scientific societies regarding the ideal treatment for spinal dysrhythm. The second trend is proliferation or generalization, which is today more than 50 centers are offering this procedure worldwide. In Latin America alone, we published this year the results of the Latin American Spina Bifida Consortium, comprising more than 300 cases with similar results to MOMS. And the third trend has been alluded today, which is innovation. Starting with the classical open technique described in MOMS trials, there are now two less invasive techniques that have shown promising results. On one hand, the fetoscopic neurosurgery, and on the other hand, the open mini hysterotomy. Yeah. So people have started looking again at the sacrosanctum MOMS criteria and wondering, should we extend them? Well, an interesting paper from the USA has pondered this question, asking 17 centers if they would offer fetal surgery for a number of maternal and fetal situations beyond the MOMS criteria. One of those was, for example, hepatitis B. And in 2019, an Austrian group showed what looks to be a first in vaccinology. A baby got its first shot, not for COVID, but for hepatitis during the fetal surgery. But what about timing? Well, the MOMS trial authors defined the recommended time frame for fetal surgery. However, if you read carefully both the original paper and the MOMS protocol, you will not find any explicit justification or argumentation for the time window chosen by the authors, which, as we know, goes from the beginning of the 19th week to the end of the 25th week. You can see here, this is the protocol, and they don't really give an explicit argumentation. Only if you do some bibliographical archaeology, you will find that the limits were translated directly from the animal models. Yeah, as you can see here, these are the sheep gestation. This is the human gestation. So if you translate this to the numbers in the human, you will see that 182, it's equivalent to 16 weeks, and that 126, which is the earliest possible repair, is around 18 weeks. So they decided to go a little bit further to 19 weeks. So these thresholds come as translations from the animal models. There are no really human evidence of what happens before 19 or after 26. And the other question that we should ask is the mom's trial window early enough? So recent research from France has shown that by 16 weeks, there is significant neural damage, and that fetal surgery probably rescues the motor neurons adjacent to the injury rather than those involved there. Yeah, as you can see here, these are different levels. This is 16 weeks versus controls of other babies which were aborted for other reasons. And you can see how there is a trend to reduce the adjacent neuronal damage rather than the neurons at the level of the lesion. So the authors reached the conclusion that significant neural loss is present before 16 weeks, and this goes hand in hand with what Juliano was saying. Fetal surgery probably rescue motor neurons adjacent to the injury rather than those involved in it, and that it's imperative to try to move earlier to an earlier surgical gestational ages. So, which are the problems, or which would be the problems for going earlier, which is the cleverest thing? Well, there are a couple of problems. The first one is skin. The fetal skin is really frail and makes sutures difficult before 19 weeks, at least with the current technology. And the other problem is an obstetric complication. The earlier you go, it has been shown by after the mom's trial, the earlier you go, you do surgery, the higher the risk of chorioamniotic separation, which is one of the main risk factors for PPROM. So based on this, many centers, not all, but many centers are actually performing surgery not near the lower threshold, but between the 24th and 25th week. Yeah. So the practical surgical window has got narrow. So why would we go later? Well, we witnessed significant advances in early diagnosis of fetal dysraphism in the last decade, particularly in the first trimester. However, it is not rare to receive, as has been alluded, late referral, especially in underserved communities. For example, in South America, according to a recent estimate, the rate of prenatal diagnosis before 26 weeks is around 5% in the public sector and 20% in the private sector. We knew this when we started our program in 2011, and when we started offering fetal surgery in 2015, we knew that if we moved or we extended the surgical window up to the end of the 27th week, we would have we will allow surgical eligibility to an extra 10 to 15% of patients. At that time, there were very few cases of fetal surgery after the 25th weeks in the literature, coming mainly from two Brazilian series, suggesting that the short-term benefits of fetal surgery may persist at least up until the 28th weeks, but this had to be assessed in bigger studies. So what we were thinking is that as nothing really magic happens at the beginning of the 26 weeks, we might be able to extend it up to the end of the 27th weeks. But there were a couple of questions. Surgical issues could arise, obstetrical issues could arise, and the main question is how late is too late? So how close can we go to the second hit and still benefit the baby? Our first experience with this was presented in the Fetal Medicine Foundation World Congress in Athens in 2018, and I will now present some updated data to 2021. So the aim of the study was to compare the maternal and perinatal results between conventionally and late fetal surgery. So this was our training period in animal models and simulation, and this is our recruitment time. So whenever we received a patient after the end of the 25th week, we would offer her surgery between 26 and 27th weeks. The latest we have done a fetal surgery has been, I think, 28 and 1 days. And the problem of doing open fetal surgery after the 20 weeks is that it's really difficult to be able to exteriorize the uterus. This is a retrospective analysis of 71 fetal surgeries. We excluded one we do in Peru, one we do, 4 we did fetoscopically, and 8 which were ongoing. So we analyzed at the end 62 delivered cases. And the group 1 was the conventional time frame, 27 cases, and the group 2 was 35 cases after 26 weeks. So the populations were comparable regarding most of the maternal and fetal variables. Of course, the babies which had late fetal surgeries had a later mean gestational age at diagnosis. And for some strange reason, anterior placenta was a little bit, significantly more prevalent in the early group than in the late group, but all the other things regarding maternal and fetal variables were the same or not different. There were no differences in the surgical times and the maternal post-surgical admission time. However, late surgeries tended to be shorter, but were not significant in this analysis, as you can see here. It was not regarding the myoplasty time, but the whole skin to skin time. This is the learning curve, and this is all the other cases. Regarding maternal results, we did not find any significant differences between the group for the following variables, which are PPROM, gestational age of PPROM, spontaneous preterm labor, oligohydramnios, abruption, pulmonary edema, chorioamnionitis, blood transfusion, and uterine scar dehiscence. We didn't have any uterine scar dehiscence, and we didn't have any blood transfusion in any of the 2 groups. There were no differences whatsoever in the perinatal and neurological outcomes. This is perinatal survival. It's around 97%. Gestational age at birth, it was very similar, 34.6, 34.5. Birth weight, RDS, necrotizing enterocolitis, sepsis. BP shunt was 23% and 14%, and not significantly different. And ambulation at 30 months was around between 75 and 80%. So and here it is not significantly different, but it's a little bit higher in the early group. So at that time, our conclusions was that our results suggested that fetal surgery for open spina bifida between 26 and 27 weeks is feasible and appears to be safe both for the mother and the fetus, and does not seem to be associated to a worse perinatal or short-term neurological outcome. Considering that late diagnosis is not unusual in our setting, a case could be made for an extended surgical window with the intention of including a greater proportion of the cases. So we were excited about this result, so we joined forces with the group of Rogelio Cruz in Mexico, who also started offering fetal surgery after 26 weeks, just after us. And this is a submitted paper, manuscript, which is now under review in prenatal diagnosis. And you can see that the results remain the same. These are 55 conventional timeframe surgeries against 76 late surgeries. Well, of course, the gestational age of surgery is significantly different. The surgery time now is significantly lower in the later group, and the interval between fetal surgery and delivery is obviously lower if you do a later gestational age surgery. There was a trend towards a higher abruption, placental abruption in the late group, but if you analyze this, you will see that it's very similar to moms, which is 6%. So actually, maybe early surgery precludes or reduces the risk of abruption, and not late surgery increases it. So extending the upper limit, gestational age limit by 2 weeks could give patients the chance to consider fetal surgery as an option for those fetuses with late detection, in which without increasing the maternal risk and preserving the potential life-threatening risk of intrauterine repair. So as a final thought, early fetal repair is definitely the way to go. to further improve the neurological results. However, it is a challenge with the current technology due to the higher risk of fetal and obstetric complication. This may be achieved in the future through instrumental miniaturization and tissue engineering approaches. Late fetal surgery, although not ideal, may be better for the fetus than early postnatal repair, especially in regions with suboptimal prenatal diagnosis and referral. Thank you very much, and I'm happy to take any questions.
Thank you so much, Adolfo. And I think that we have covered different approaches to repair spina bifida. And in this last talk, we have covered a very important question that is very commonly asked to the people that we're doing fetal surgery. It's also a very common situation in our clinical practice if we extend the gestational age or not. So I think that you have answered many questions that people might be having. We have a comment from Dr. George Davis for Dr. Echegaray. And he was saying that he was talking as a co-author of the MOMS trial himself, that there were two reasons to limit the gestational age at surgery at no longer than 25 and 6. And it was because of the early studies showed a dramatic decrease in the benefit for the second hit. And the other one was in order to have more homogeneous data to not to act the gestational age at surgery as a potential distractor. So based on what you showed, there were no significant differences in the ambulatory status of these babies, right, Adolfo? Do you see any differences in the motor function when you assess these babies at birth? Do you have any data supporting that?
Well, I think in order to show, and thank you for the question, in order to show those differences, you might need to compare babies which were operated maybe at the end of the mom's window, like 25, 26 weeks, against maybe 19 to 20, because there I think that there might be significant differences. In our data, in which we are comparing median times of surgery like 24 against 26, I think that there is a difference which is maybe 80 against 75, but it's not significant. It's not significant. So I think you need to probably compare really different gestational ages at surgery to be able to show a difference. But I think it makes sense.
Adolfo, again, congratulations on what you guys did. Again, there's a lot of discussion, as Dr. Cortez mentioned, regarding of, extending this gestational age of the, intervention after 26 weeks. And again, all of us know that, on the RCT of the MOM trial base, they try to have a homogeneous group of the patient, but we passed about a decade now. And again, many things change, and many of those criteria can be challenged. And again, I review your manuscript, but it was pretty well done, and it's very interesting, and had a lot of good points on it. But let me ask you and Ramin this question: do you guys think there's any way that we can extend above 28 weeks, or that will be the max?
Well, thank you for the question, Shami. I think that there are technical issues for extending, and the main question here is how close can you go to the second hit? So, and that, another way of rephrasing that question is any fetal surgery better than a neonatal surgery, neurosurgery? So maybe you will gain some benefits up to 30 weeks, but so when does the second hit really hit? So I think that doing open fetal surgery after 28 weeks is really challenging, because the uterus is really big. And when we did cases at 28 weeks, it was really, we were worried if we would be able to put it back again inside the womb, inside the abdomen. But maybe by fetoscopic techniques, and I know that Denise has done some after 28 weeks, and maybe you could extend it up to 30 weeks. But in order to be able to recommend that, I think that we should have really better data.
Ramin, what is your thought?
I do think that the question regarding the second hit and timing is important, but maybe a little bit more theoretical. Drawing a solid line and saying that at one point it doesn't help anymore, I think is not the way biology works. Also, another surrogate that can be used is looking at fetal movements by ultrasound. So if we're worried about motor function, you would assume that if you all of a sudden hit 28 weeks, is there a sudden drop off in motor function? There's an ability to assess lower extremity movements by ultrasound at each motor level. And you can look at basically S1, L5, L4, as you go up, if you see ankle movement, knee movements, hip movements, etc. We have a paper that was submitted to ISWAG. Dr. Lucas looked at motor function of the lower extremity and did not see a precipitous drop-off at 27, 28, 29 weeks. So I do believe, particularly as you improve the maternal risk profile. So don't forget, for the mom's trial, there was significant risks to the mother. So the risk-benefit ratio had to be in such a way to strongly justify that surgery. As we move into a surgical procedure that is minimizing the risks to the mother and to pregnancies, and we can document that there seems to be preserved motor function between a 26-weeker versus a 28-weeker on ultrasound, I do believe that it's justified to perform this surgery, particularly fioscopically, at 28 weeks gestation.
Could I just say something else? Yeah, one of the problems with what Raman says is that sometimes the motor function just not only reflexes inflammation, but also, as Dr. Belfort said, there is the stretching there. So that's why we can find 18 weeks babies with talipes. So it's probably a multifactorial thing. And the other thing I'm worried is of course, we do the motor function assessment as proposed by the people from Barcelona, but I think it has never been demonstrated how reproducible it is. So should we make decisions based only in ultrasound movement of the baby?
That's a very good point, Adolfo.
Okay, go ahead. Please, go ahead, Magda, sorry.
I think it's a very good point, and I'm just trying to capture different things that have been presented here so that the audience gets a clear message. Juliana, in her presentation, talked about the motor function as a predictor for the ambulatory status later on. Dr. Smythe has also talked about, and we're discussing the aspects of assessing the motor function prior to surgery. And also Dr. Echegaray is bringing up the same point. We have also, from our center, we have published a couple of papers on this. And I think that it can be brought up as a new piece of evidence that the assessment of the motor function prior to surgery of the baby is an important piece of information to keep in mind, because we have seen how it is those babies that preserve the motor function at that time, those that might be in a better place to be able to ambulate independently after 30 months of life. And I think that this is an important concept for counseling and also to incorporate in our clinical practice. So that's my 2 cents on that. Yeah, Tim, go ahead.
Can I give our kind of Toronto view on that? So for us, motor function is really kind of a marginal gain. And I think that if parents come and ask us for fetal surgery, I think the real reason to do so is to prevent VP shunting, because that is ultimately what affects quality of life. Motor function at the age of 30 months or even 5 years is not such a great thing, because or not such a great parameter to assess and to try to convince parents to have fetal surgery with, because even though these kids may be walking when they're small, throughout their lives, they will have further degeneration in their nerve function. They might develop tethered cords, they get heavier, and even good motor function at 3 years of age will not mean that they will be walking when they're teenagers. And many of our kids, certainly in our population, who are walking when they're young, prefer to go to wheelchairs or walking aids to be able to keep up with their peers later on. And yes, they may have a little bit easier transfers and things like that, but really motor function is not the main part of our counseling here. And if kids present or fetuses present with club feet, we would have absolutely no issue doing fetal surgery on them and saying, well, look, we're not going for the motor function, we're going for reduction in VP shunting. Yeah.
Team, that was a great point, but let me ask you another question. If you see a, huge ventriculomegaly, that means it's about, 15 and you had a clubfoot, do you still offer the intervention to your patient?
We would offer, well, above 15, we would consider. 18 would be more of the cutoff that we use to really say that you're probably not going to gain much in terms of VP shunting, although we have been surprised, and there is fetuses even with large ventricles that end up not needing a shunt later on. So it's not an absolute contraindication. We would certainly include it in our counseling and be much more pessimistic, but we would not use 15 as an absolute cutoff to decline surgery. Yeah. And I must say that so far, obviously, we don't have a massive experience, but we've got now 40 fetus in our cohort. We've not had a pregnancy where we had both and the very large ventricles and club feet at 20 weeks. Yeah.
Adding to what Tim says, I think that there's a third thing, which is reversal of hindbrain herniation, which we tend to forget. And having a decompression neurosurgery after birth is really a really bad thing. So I think that hindbrain herniation is another forgotten benefit of fetal surgery.
Definitely. There's a question in the Q&A box for Dr. Smythe about the totally percutaneous approach. And so they're asking, Dr. Suwan Mehra is asking about the earlier PPROM. They're asking if it's related to the number of ports or the technique for the port placement, if there's any relationship. And also if you have any thoughts about the maternal BMI.
So, as far as maternal BMI, we've recently amended our protocol with the FDA and our IRB to extend it to 40. So we are now offering surgery up to a BMI of 40. In regards to our PPROM rate, yes, our PPROM rate is higher, and our average gestational age of delivery, as I mentioned before, is around 34 weeks, which is equivalent to the open maternal field surgery, but is less than the total laparotomy. So the laparotomy-assisted approach. The reasoning does not seem to be related to the number of trocars. As far as I'm aware, when we compared that analysis, 3 versus 4, we still have small numbers, but there was no difference. I do believe it has to do with our ability to not close or stabilize the fetal membranes. As you saw in the videos that were shown for each technique, both the open maternal field surgery technique, the mini hysterotomy technique, and the laparotomy assisted fioscopic technique. Each one of those had a procedure that was done to plicate the fetal membranes. And that's the one thing that we cannot do with the total percutaneous approach.
I think there's another question from
Thanks.
Jimmy.
Raman, do you know of anybody working on a device to attach the membranes with a total percutaneous approach? Because that's really the only thing that is holding us back from applying this, and that's really the way of the future, right? Because the laparotomy assisted approach is really nice, but you still have the massive maternal morbidity of the laparotomy. It's good for the fetus, but not so good for the mom. Do you know of anybody working on a device to help you?
Yes, I do know of several centers that are working on these devices. I actually have signed non-disclosure agreements, so I cannot talk about that. But I do know that there are people who are working. But let's speak from an ideal point of view. I think what you're saying, Tim, is a very important one. we're slowly edging towards a world in which we can provide the fetal benefit of the physioscopic approach, not just necessarily for spina bifida, but as we're able to enter and do complex fetal surgery using multiple ports in a CO2 environment and extricate ourselves from that situation with minimal perturbation to the pregnancy and to the mother, you can imagine that the next generation of fetal surgery could be much more complex, and that would be the ideal. So yes, I think we're inching towards that world, but as of right now, you almost have to kind of pick your poison. With the laparotomy assisted, it's not just to me at least, it's not just the laparotomy itself, but it's the potential hemodynamic derangements associated with the deep general anesthesia, the recovery time, and also the dose of inhalational agents. There is a black box warning for children, from age up to 2 years, and their risk of potential neurological sequelae with the inhalational agents. We don't know what that risk is to the fetus. If we can minimize the use of the inhalation agent by using, like Dr. Lapa almost uses no inhalation agent. It's almost complete total intravenous anesthesia for her cases. So there could be a time when all these potential advantages will converge into one technique. But as of right now, you do seem to have to pick your poison. And we do try to be able to offer both approaches and tailor it depending on the clinical situation.
Great point, Rami. I mean, reality, also bring it up that, everybody will go towards the percutaneous. There's a question from Dr. Jimmy Espinoza from Adolfo. Did you guys look at your subsequent pregnancy and figure out on a mini laparotomy what is the percentage of your uterine dehiscent or thinning?
Thank you, Jimmy, for the
Juliana.
question. So, for Juliana? Okay, sorry.
Yeah, it's about the mini hysterotomy in particular.
Can you repeat, please? Sorry. The question about the uterine dehiscency, is that one?
Yes.
We don't have the data about the subsequent pregnancies. We have some cases, a few cases that the patients have already had another pregnancy, but we don't have this data to discuss. So we don't have, only few cases.
Juliana, can I ask you a question?
Sure.
With the mini hysterotomy, considering the size of the incision that you're doing, that sometimes is like 1.5 centimeters, would you consider allowing these pregnant patients for a vaginal delivery?
Oh, no, not now. Some patients that they are going to the vaginal delivery, but we don't allow it. So we recommend to go to the cesarean delivery, even with a small incision. We don't think it's safe.
And what gestational age do you do the C-section, the elective one?
No, 37, 38 weeks.
I wouldn't mind getting some input from everybody in the group here. What do you think is an acceptable incision to allow for vaginal delivery? Is that 3 centimeters, 2 centimeters, 1 centimeter, 5 millimeters? How small do we need to go?
Oh.
Well, what I can add, Tim, is that in the data from the Latin American Consortium, there were actually 3 babies which were born vaginally with classical hysterotomy, not in an elective way, but just because it happened. It was not in our center. I don't know where it was, and there was no complications. Of course, you cannot say anything about that, but we don't really know what would be the threshold. And if you bring the mini hysterotomy very close to the sum of what would be the ports, maybe it would be the same, isn't it?
Tim, I'm curious now.
We've had one patient deliver after a fetal surgery 24 hours after, and she was all of a sudden fully dilated and had not ruptured on a scar that was just made 2 days before, right? So certainly these scars hold more than what you would think. But I was just wondering, if we're developing new techniques, how aggressive should we be on reducing the size of instruments? And do we really want to make it, or do we say, well, we can just use plain laparoscopy trocars, we can put in a 10 millimeter trocar and still labor them vaginally?
And that's a good question. Again, if you manipulate or extrapolate data from the classic C-section and being a vaginal delivery, and uterine rupture will be close to the 5%. With that said, again, if you're coming down to the much smaller difference, your risk will be less. And if you have the patient in-house and your team are pretty available and ready, even with the uterine rupture, most probably you will have a good outcome for mommy and baby in the worst scenario.
And from our experience, Tim, we have published that doing induction of labor, administering like cervical ripening medication, and then titration of oxytocin IV in these moms that undergo the 2 trocar that we use for fetoscopic spina bifida repair is safe. We've never had like an adverse event, and from our experience in over 100 cases now, we've had a very good experience about labor and delivery management of these patients as low risk.
But your trocars are only 12 French, right? So that's roughly the same as what we do for a laser.
Yes.
What if? So that's 3.4 millimeters or so. What if we go up to 1 centimeter? I don't think anybody knows, but I just wanted to know how you guys felt about doing that. Yeah.
We're going to speculate, but there's no evidence. So, Raman, do you have any thoughts about the vaginal delivery of these patients, and have you thought about like the thickness of your trocars and the safety of that?
So our trocar for the camera has a inner diameter of 5 millimeters. The outer diameter is around 8 millimeters, and as I mentioned before, we do not close the uterine defect, and all of our patients are counseled that they can deliver vaginally at term, and we have had no problems so far. Don't quote me on it. I think the C-section rate is less than 50% so far in our patients, but we're still a new program. Our oldest child is 2.5 years old, so we haven't had the opportunity to look at future pregnancies yet, but Dr. Lapa's cohort, she's done well above 100, and she's had no problems with future pregnancies. The size of this hole, obviously, the bigger it is, I think there is a bigger risk. I always feel uncomfortable when we talk about the hysterotomy performed during the pregnancy and comparing it to what happens at time of delivery, because with time of delivery, the uterus by definition involutes, whereas every incision that we make during fetal surgery, there's further expansion of that wound. This is the only surgery in which after a surgical procedure, you put tension on the wound. Every other surgery that I'm aware of, after the surgery is completed, we advise the patient not to put any tension on that wound. So I think that delivering remotely from the time of the hysterotomy may even further weaken that wound and put that pregnancy at a higher risk, particularly in the next pregnancy, of having at least a window dehiscence or rupture.
Very interesting point. Thank you so much for commenting on that. So it is 11 a.m. over here in Houston. I would like to thank all the lecturers. I would like to invite the attendees that are connected to this meeting that I would like to announce that we're having a second Spina Bifida webinar on December 4th. It will be again on a Saturday at 9 a.m. Houston time. We will continue with Spina Bifida, and we will cover radiology aspects of Spina Bifida assessment in the fetus, developmental aspects, pediatric neurosurgery aspects, and also cutting-edge research on stem cell applications on the repair of Spina Bifida in the fetus. So I think it's going to be a fascinating webinar as well. So you will be receiving the emails in order to register for that one. Shami, do you want to do the final remarks and closure?
Thank you very much again, everybody. All speakers. I know some of you it's pretty early and get up and do that kind of stuff here. But yeah, thanks to our attendants, and hopefully we see you all in future. Have a great day and great weekend.
Thank you.
Thank you.
Thank you.